folks, it's Wednesday. In front of us, Senator Rasmusson. Do you want to go ahead and talk about your bill, Senate file? What are we looking at here? Do we have a Senate file on this? Go ahead, Jordan, yes, it's all yours.
Thank you, Mr. Chair. And just to put the bill in front of the body, I would move that Senate file 626 be recommended to pass and be re-referred to the Committee on State and Local Government, because this is dealing with, appointments by the governor and, who's in the cabinet and those types of functions. This is supposed to go to State Government Committee. I anticipate it'll come back to this committee at some point, but just want to make sure we have enough time to get it there. And then, Mr. Chair, I also have the A2 as an author amendment, so I'd move the A2 at this time and happy to describe what it does.
Members, the A2 is in front of you. If you want to just give us a brief overview, since it puts the bill into the form that you'd like, we'll go ahead.
Thank you, Mr. Chair. So the A2 does two things. One is it makes a technical correction that was spouted by council, and then the second is that it establishes an advisory council on direct care and treatment. And what we did here in terms of the membership is we kind of took the best of best. We took the types of roles that were supposed to be on the executive board, and so whether it's a licensed healthcare professional, people who have experience in care coordination, a licensed physician with experience serving behavioral health patients. We also have a union representative and a member from the Association of Counties. And then we also have a member appointed by the National Alliance on Mental Illness, Minnesota. And so we really just given feedback from the committee, and Senator Fate felt like it was important to put this marker in the bill to show that regardless of if we have a commissioner model or we have an executive board, that we have stakeholder engagement moving forward. So I'd ask for member support on the A2 authors amendment. And
to that, Senator Jordan, thank you. I see that you have people with lived experience. That brings that balanced perspective. So any questions for the good senator? All those, Senator Ruck, you got a question or nope? A1, all those in favor of the A2 amendment say aye. Aye. Opposed, same sign. There it is. The bill is in the order that you'd like, correct?
Yes, thank you, Mr. Chair. And I know we had an opportunity to talk about this bill at length, and I think the conversations are going to continue, especially in state government. And my pledge to folks is to continue to working with all stakeholders, whether that be the staff at Direct Care and Treatment, members of this committee and other committees, to try to make sure that we're enhancing accountability for the important, critical, life-saving work that is done with Direct Care and Treatment, and ensuring that we have the right governance model as this important work is being set up as a separate agency.
Thank you. I see you have Dan Storkamp is going to be talking today. You want to bring him up now, or do you want to?
Up to him, Mr. Chair.
Any questions for the good senator? Senator Wickland.
Well, thank you, Mr. Chair. I guess I would like to hear, since this advisory council idea is just brand new to us today, would Mr. Storkamp have any comment on that? It doesn't change some of the major differences that you're making in terms of the structure, but I would appreciate his comments on it. And if there's anyone else who would have any comments on this, since we didn't get it ahead of time and it's new to us, if there would be any other stakeholders who would have comments, I'd appreciate that.
Mr. Storkamp.
Mr. Chair, members, Senator Wickland, we just received this as well, and we're digesting some of it. As we look through it, I think, as the senator mentioned, it is the best of all put together into one advisory group here. That's a very extensive advisory group, and that's one of the things that we might want to talk about is how big do you really want to have an advisory group? I think this is pushing almost 15, 16 members in that process, and the more members that you've got, the more difficult it is in the moving things through. But again, we'll digest a little bit more and probably have more comments during state government or back in this committee.
Senator Wickland, follow up? No. So, and with that, this is not a governance board, correct? This would be an advising and assisting board. Is that correct, Senator?
Thank you, Mr. Chair, and thank you, Senator Wickland, for the question. And it's capped at 15 members, appointed. And so I am totally open to feedback from any stakeholders, from the team at Direct Care and Treatment and members of this committee, committed to be working together to ensure that we have the right perspectives on this advisory board and that it's actually helpful in terms of advising the commissioner on the important work that DCT does.
Thank you, Senator. And with that, my assumption is you and Dan will be part of that conversation going forward on the content. So thank you for taking a look at that. Members, questions? No? Senator Rasmusson, any final thoughts before we, pardon? Wickland, you got another one?
Yeah.
Sorry, Senator?
I just, if you're moving to vote on or were you going to have any other discussion?
Yeah, we had the discussion the other day, and if there's any, more discussion, absolutely, we can go on that. But yeah, eventually we'll move as amended and pass it to local, state and government local. So go ahead.
Yeah, I was going to say that after listening to the discussion the other day and, thinking about it more, I'm not going to support this bill as it's leaving. I don't think that this is the appropriate way to go forward. I think the executive board with a CEO that is running a system like that is more appropriate and has a better chance of succeeding where we have had issues before. I understand you have this idea that there's not enough accountability, but I don't think that the model you're proposing will benefit the people in the system that need more of a hospital system type overview or oversight. So I hope you keep discussing and learning from others, but I think an appointee by the governor, yes, the governor is directly accountable for that person, but I think that person can come and go more frequently, which I think is possibly detrimental to the stability that the people in the care of the state need. I think the executive board concept with the CEO was well thought through, and I supported that, and I think that I don't see a reason to deviate from that at this point. I also would have concerns that there's a lot of work that has gone into making the conversion. We got an update from Mr. Sorkamp about the status of all the different plans that had to be executed. And the timeline in your bill, it doesn't seem to me that would work to switch to this other structure of an appointed commissioner, plus the cost of it. So I assume that this bill will end up coming back and it will have a fiscal note that you'll figure out, how much will it cost for us to do the work to move to this commissioner model. So those are kind of my thoughts today, and I guess we'll see how the bill proceeds.
Thank you, Senator Jordan. We're good. Yeah, thank you for that, Senator Wickland. Going to Senator Mohammed and then Senator Abler. Senator Mohammed.
Thank you, Chair. I will just echo what Senator Wickland said, because I do agree. I think this, I'm hoping maybe we'll have more time to discuss this bill before we move it from committee and lay it over, if that's possible. So that's my ask for you, Mr. Chair. And Senator Rasmusson, it sounds like right now that the executive board, they do have, or have they hired an executive director for because that's a position that should be open.
Senator Rasmusson.
Thank you, Mr. Chair, and Mr. Storkamp should feel free to jump in if I say anything that's incorrect. Currently, there is a CEO who is running Direct Care and Treatment. That individual, I believe, is an appointee of the DHS commissioner.
Correct.
And basically, this board isn't effective yet. They will be empowered come July 1st of this year. And so the board hasn't hired or selected this, kind of long-term CEO. And so in terms of disruption to the agency, it actually, I think what would likely be the case is that if we were to have this become a commissioner model, you just wouldn't have the executive board assume those responsibilities and go through the process of identifying and hiring a CEO. You would likely have the individual that is appointed, be reappointed, or if they didn't want to do that role, you would have the governor find another suitable candidate to appoint.
Senator Mohammed.
Thank you, Mr. Chair. Follow-up, Senator Rasmusson. Is the board, if they're sort of ineffective, like you said, are they currently meeting? Are they having meetings on the calendar currently?
Senator Rasmusson.
There are some of the positions that have been appointed by the governor, and I believe that they're doing organizing work, and Mr. Storkamp can talk more about that, but they are not officially the head of direct care and treatment at this time. That'll take place on July 1, but there have been some appointments. There's been, I think, one person who's resigned from their appointment already, and so that's, I think, their current status. But Mr. Storkamp can add more.
Dan, you want to follow up?
Mr. Chair, and members and Senator Mohammed, the governor's office actually appointed the 6th member of their area to appoint in end of December. We had our first meeting in January. We also had a delegate from the counties, a delegate from the unions that have been appointed, and the commissioner was the 7th person on that. And as Senator Rasmusson said, one of our members did resign due to some conflicting concerns they've got for conflict of interest. And the governor's office is now filling that position. We have met the first time. They've appointed a chair as per statute. They have 5 meetings planned on touring, as well as just getting background information about direct care and treatment and all our programs, as well as all the civil commitment processes. And then, as Senator Rasmusson said, on July 1 is when the board will transition the authority from the commissioner of DHS to the board itself. And in statute, it says the CEO will be, at that time, will be appointed as the CEO of the organization under the new board.
Okay.
Yeah, go ahead, Senator.
So they are currently meeting then? Mm-hmm. Okay.
Mr. Chair and Senator, correct.
And are their meetings public?
Mr. Chair, Senator, at this time, the statute allows us to do the training and education without it being public. July 1 is when all their meetings will be public.
Okay.
Senator?
Thank you, Mr. Chair, and thank you, Senator Rasmusson. I will sort of reiterate what Senator Wickland said, and I'm kind of following some of the concerns that she has. I think that although they might not be meeting to the standards that we do have, it sounds like that they are having public meetings, and they're functioning. And so maybe we figure out what we do with this bill, and I hope we don't move it from the jurisdiction of this committee and we keep it here.
Thank you, Senator. What we're doing is it's going to stay within us. I mean, we started this debate, and we'll go to Senator Avery, but just to follow up, I remember at the end of session when we had this debate, I think we were split. This committee was split on what this board should look like. I remember that debate very well. It's going to stay here. It'll go to state and local government, then it will come back to us. And I believe, since to Senator Wickland's point, there's going to be some cost to this, so it will be laid over probably into our finance package. So, there's a lot of turf between, the end zone and the 10-yard line between now and then. I didn't say that right, but, I didn't play football. I played baseball. So does that make sense?
Will we get a fiscal note?
Yes, that is correct. It's good. Senator Abler.
Well, thank you, Mr. Chair. I just want to remind you, red zone references are very painful for us Viking fans. And so...
He's funny.
Sorry, Mr. Chair, that's like so close. So close. Yeah, it's too soon. I'm just sorry, Mr. Chair. Anyway, so I was going to make a different joke, but I was going to mention, so the committee is kind of like the House, not organized but not organized, and what are they doing really, who's in charge of anything. Anyway, I think this is a productive direction to go. I just want to, maybe Mr. Storkamp can ask, when was the first time we had state-operated services like the MSOCs and where we delivered care? It'd be the state hospitals probably back then.
Mr. Storkamp?
Mr. Chair.
You don't have to remember exactly. just
Senator
the-
Abler, I would say that this goes back to the 1800s, where the whole direct care and treatment roots began with the first mental health institution that this body actually approved, and we operated at that time. It then grew into DHS, and then under DHS, it actually grew into several of our different 5 main program areas.
All right. Well, thanks. I just wanted to remind people that somehow, for 100 years, nobody minded having a commissioner oversee your stuff, and now, and some of us think that actually wasn't the worst of all the ways. So I'll leave it at that. So just to, and Mr. Storkamp, I appreciate you're kind of the ping pong ball here, and I appreciate that. And you know, either way, you're going to have a pretty good job, I hope, and maybe you get a promotion with this bill. So that might bias your support. Thank you.
Mr. Chair and
Mr.
Senator and committee
Campbell.
members, we are proceeding as the statute has today, putting the board together, and
Yep.
if the body decides that their wisdom that needs to change, we will do appropriate to make that happen. But we do feel like a ping pong ball at times. Thank you.
Yeah.
Senator Abler.
Well, Mr. Chair, I hope that every erstwhile state employee could listen to that sentence. We're proceeding with the statute, and if in your wisdom you change it, we're going to do that. Anyway, I appreciate you, Mr. Storkamp. Thank you very much.
Thank you, Dan. You know, this debate, again, this committee, it's 50-50. I mean, we're, you know, should it look like this, should it look like that? This is why the conversations are happening. So Senator Omar Fatah.
Thank you, Mr. Chair, and thank you, Senator Rasmussen, for bringing this forward. I had a question about the advisory council structure and membership and the current executive board structure. So currently, there's 6 members, you said, on the executive board. Is that correct?
Mr. Storkamp or Senator Rasmussen, yeah.
Mr. Chair, Senator Fateh, we've got 7 members
7.
total, actually 9 members total. 6 members are appointed by the governor. You've got the commissioner of DHS that's on it, and then a county representative and a union representative from the unions that represent DCT staff. And the two union, the union and the county are non-voting members.
And then from that, we want to go ahead. Senator? And then of those 6 appointed members, I'm looking at the requirements for the membership. Would they still fit in within these requirements, those 6 members, or would any of them be no longer able to serve?
Mr. Storkamp?
Mr. Chair, Senator Fateh, that is correct. They are exactly the same categories that we've got on the board today for those 6 appointed members.
I'll just say.
You know, one of the things to look at, and I think in this, what you helped add to this, I think these are some of your additions, is the membership, the 4 additional members, but the 2 members lived experience plus the union. Right now, the union member doesn't have any kind of, you know, jurisdiction or whatever the word is on that, because it is a governing board. But when you have an advising and assisting board, now everybody's really looking at what's the matter at hand? How do we do our DCT? And so I kind of like how you guys made that up, so, or, you know, put that into being. So with that, you want to follow up?
No, yeah, I just appreciate, and
Yep.
I spoke with Senator Rasmussen last session and then earlier this year as well. I am supportive of this bill. I'm not comfortable with the executive board model. I voiced that concern to you, Senator Hoffman, last time. I think that we need some democratic accountability, and I think the structure with having an advisory council with a commissioner so that we can better meet our needs. I heard concerns also last year and this year about a disruption in our agency, but right now there's a disruption in people's lives, and whether or not we have this model or the executive board model, we have the core root issue of just not enough funding, not enough beds, not enough services for people, and people are overall struggling. And to tackle that, I think that the commissioner model is more appropriate so that there is some accountability going to the top. And I appreciate you, Senator Rasmussen, for bringing this.
Thank you, Senator Fateh. Going to Senator Makewaid.
Thank you, Mr. Chair. And Senator Rasmussen, I really want to appreciate your work on this. And I think it's important to say that, yes, it is like 50-50, and it's not coming from like philosophical or ideological places. Like it's really in the details and kind of figuring out where we land. And I think it's like the really boring but good work that we can do as a legislature. And so, Senator Rasmusson and I were texting last night about this bill. And I actually spent some time thinking about like, how would I want to explain it? Because I feel like I've asked questions to make a point. And I think the thing that keeps coming up for me is, obviously it's in the name, direct care and treatment, right? But it literally means that this is the one place in our state government where we are in the direct care of people's health care and their treatment. Unlike, we're paying for it through Medicaid, or we're, delivering services or doing waivers, right? It's really different. And the idea of having, ostensibly, the person in charge could change every 4 years, which means every 4 years there could be a totally new person overseeing DCT. And that kind of, that disruption, its susceptibility to, we could shift left and right, and that kind of disruption to treatment, it really worries me for the population of folks we're talking about. And so, I'm not, as I told you, I'm not comfortable with this bill as it is right now, and I'm glad that's coming back here. Some things I wanted to offer that might help put some of my concerns at ease. And I apologize for coming in late. The amendment, I don't think I totally understand it. We had an advisory committee, now we just have advisory council. Is that the summary?
So go ahead, Senator Rasmussen. Yeah, the question is on changing your A2 is creating the advisory council and then adding some people that have been left off in the past. It gets up to 15. So go ahead if you want to add to that, sorry.
It's fine, I get it. I just want to make sure I wasn't missing something broader. So a few things that I want to add for here that I think as this bill comes back to us. One, we have at the federal level, the FBI director ostensibly serves for 10 years, right? Maybe a length of term that could be longer than a governor's term to try to take the politicalness out of a commissioner style piece. If you're concerned, and I do hear what you're saying about, the governor can't fire the CEO. If you want to come up with a set list of things that wouldn't be like, I don't like this healthcare, but I can't fire someone for that, but I don't like that you've, run this into the ground with money, right? So if there's like a separating of duties and powers that might trigger the ability to let somebody go. I do think I think we should stay, I really think we should stay with what we have right now in statute. But I do think beefing up the number of meetings that are happening, because I do take your point very well about, 4 meetings and it can be pretty perfunctory. I've served on boards before, right? I know how easy it is to miss robust pieces of the work when you're only meeting a few times a year. And so just some things to think about, because I think you're coming at this from a place that is well-intentioned, and I hear your concerns and I know you hear mine. And so if we go your route, then I think some things to keep the politicalness out of it would be helpful. And if we stay this route, then I think some concerns about making it more robust and to accountability would be helpful.
Senator Rasmussen.
Thank you, Mr. Chair, and thank you, Senator Makewaite, and I appreciate the dialogue on this too. And I think the great thing about this issue is I think everyone in this committee kind of has the same goal, right? Which is making sure that we have a direct care and treatment agency that serves Minnesotans really well. And I like those specific ideas, and I've also just wanted to mention to the committee, I've in early conversations received some feedback from direct care and treatment on some other things that we could do. For example, putting specific qualifications in for this commissioner to make sure that they are someone who has the appropriate medical background and doesn't, isn't simply just a political appointee, but someone who's truly a professional who's guided to do this work. And so I think if there are some concerns around that, those are safeguards we can definitely consider. And I anticipate, when we get to state government committee, which I also think Mr. Chair, Senator Makewaite serves on, maybe we'll have some ideas to address those concerns.
So as you two, I like what's happening here is the dialogue. When the institution is controlled by somebody from that institution bubble, so when you started to say it was somebody with that, effective medical background, maybe it's worthwhile vetting out. It's a social services entity. I like where you're going with this. It's like, how would that look, or what would it look like? So I encourage you to bring that piece up on it, right? That's really, yeah. And that was the whole thing when I saw what flipped me on this conversation. Because last year I was we were 50-50 on this committee, and I was on the side saying, oh, no, we should look like a hospital board. But then when I looked at the makeup of the board, my mind went, well, wait a minute. This doesn't have the people that work there, people that, you know, our AFSCME brothers and sisters who are every day doing their work every day in and day out and understanding what it, you know, it's like, how is their voice being represented in a voting capacity? It wasn't. And it was like, and then you looked at the 6 that were appointed, and it was like very professional feeling, and it didn't get people with lived experience. And so it was like, is this, and then I started to think, is this the right thing to do? And so I'm glad you guys are still having this conversation, and this is the best committee to have that conversation. So my assumption is, yes, all right. Yes, Omar, did you want to follow up on anything? We're good? Senator Ackie, anything over on your end of the world? All right. Members, Senator Rasmusson, you renew your motion to Senate File 626 be recommended to pass and referred to State and Local Government Committee. So be it. As amended. Thank you, Senator Utke. There's 2 things about Utke, right? He does as amended. He makes sure we do that. And I'm surprised that it was Wickland who asked for the fiscal note and not him. Aren't you blown away on that one? Because usually isn't that his job? I'm glad you're smiling. So all those in favor say aye. Aye. Opposed, same sign. No. It is passed. Thank you, An, and you're bringing it back here. So thank you. As we transition, Senator Rasmusson, you got the gavel. Natasha Mers and Josh Berg, we finally get you 2 up here. Is that Christy? How we doing this? I got Acute Care Transition Advisory Council report, the PACE report, EIDBI licensure study, and then Obsolete Rules report. So you're coming up. Are you and Natasha and Josh going to do the first one? You're running the slides for all of them? All right. So as you're getting those side up, members, we also have, it looks like Natasha Mers, you're going to be up there. Well, you and, there you go. You guys just find your place there. We also have some folks online, David, right, on some of those. But in this one, members, it's the council report. It's slated to go 15 minutes. I don't know if that's going to happen, but we're good with that. Christy, are you set? No, well, Absolute's 5 o'clock. Yeah, we're good. I think we're good. So, members, who wants to introduce themselves first for the record? Assistant Commissioner.
Mr. Chair, members of the committee, for the record, my name is Natasha Mers, and I am the Assistant Commissioner for Aging and Disability Services and Complex Transitions at the Department of Human Services, and pleased to be here today to present the Acute Care Transitions Advisory Council report with Mr. Berg, our co-chair. So I will hand it off to him and Ms. Grom.
Josh, you want to tell us who you are, Mr. Berg, for the record?
Sure. Thank you, Mr. Chair. Josh Berg, co-chair of the Acute Care Transitions Advisory Council. Day job is with a nonprofit called Accessible Space, and do a variety of other things as well.
And Christy Grom, we know who you are, for the record. Christy Grom, DHS, you're good. Assistant Commissioner, the mic's yours. Thank you.
Thank you, Mr. Chair and members. So I am here today to provide a summary of the recommendations of the Acute Care Transitions Advisory Council. I'm also providing some updates on the work that DHS has been doing alongside the council relative to complex transitions. So before I open, I just want to say that I really have appreciated this council and having the resources to operate it. It was a very collaborative experience on a really hard and complex issue, and I'm very excited to share the findings and recommendations and continue the dialogue. So the slide that's up here really is just about our vision for what we want in Minnesota that may not be occurring for everyone right now. And it is really a focus on Minnesota establishing and maintaining a responsive statewide system that's accessible to people, so that they can live in their communities and access acute care or hospital services when it's appropriate. And then when those services are no longer needed, that they have timely and high quality transitions back to their community. So that very much is kind of the founding goal and vision for our work, both in the complex transitions team at DHS, and is also very well reflected in the vision that the Acute Care Transitions Advisory Council set. So this slide is just a little bit of color for your lives. It is a visual representation of the vision that the Acute Care Transitions Advisory Council established in the initial meetings. So I think the takeaway here on this slide is we are talking about trying to create a system where people move more smoothly through different levels of care and different types of service transitions, and they're not getting stuck in acute care settings, and that they have access to high fidelity wraparound services and supports that prevent avoidable hospitalization and facilitate those timely and high quality transitions when hospital services are necessary. So I'm going to talk about the purpose of the council, share some updates from the DHS perspective, and then I'll hand it off to Mr. Berg to talk with more specificity about the council recommendations. So the purpose of the Acute Care Transitions Council, authorized by the legislature, is to improve regional capacity for acute care transitions, talking about roles that people play in the system, and creating a data collection, measurement, and evaluation system that really helps us understand the scope and scale of the problem. And within that context also, we know that it's extremely important to design statewide strategies based on data collection and analysis that focus on addressing geographic, racial, and ethnic disparities in outcomes that we are concerned about. So that's the council's charge. I want to just make a quick note distinguishing between hospital decompression and acute and complex care transitions. During the height of the pandemic, I'm sure you all remember times when the hospital systems were at full capacity and there was not capacity to help people that needed access to respirators, ventilators, and things like that related to COVID. There was a very specific effort in state government working with hospital systems at that time called hospital decompression, designed to really clear beds, to get people that didn't absolutely need that level of care into some other level of care so that if someone needed hospital care, there was a bed available for them. In contrast, the goal and the vision for acute and complex care transitions is really to help people get access to services and have high quality transitions and eventually focus on their best life in the community. So the hospital decompression is certainly, we've learned from it, it's informed our efforts, but the focus and goal of complex care transitions is a more statewide, sustainable system that's focused on the experience of the person and how they move through our different types of healthcare in Minnesota. So before we get into the meat of the Acute Care Transitions Advisory Council report, I did want to share with this committee that using federal funding, the department has been operating a complex transitions team that is sort of our first step and our first effort to really address this at the DHS or statewide level. And so we have been successful in establishing kind of 3 regions of the state and hiring transition coordinators that are receiving referrals from institutions, hospitals, and lead agencies, and then triaging them and seeing what added value can the complex transition team coordinators bring to that situation to try to get to a better outcome in terms of either a faster transition if that's what's required, a more comprehensive transition. This team will also follow folks up for about 6 months post-discharge to make sure that they're not getting readmitted because the transition plan or the discharge plan wasn't being effective. So I'm pleased that we've been able to stand this up with some fairly modest resources and really help us kind of jumpstart the efforts that I hope will be continued through the recommendations of the Advisory Council. I'm not going to go too much into this slide, but the point here of the approach is that in order for someone to be eligible to, for DHS to take a referral from a hospital or a system, we have to have some type of a hook or a connection for DHS to be involved in their lives. So they typically need to be on MA or likely eligible for MA and in the process. We know that sometimes applications for MA can be the issue. So we never turn people away because they're not on MA, but there has to be some sort of future plan that that's a benefit set that they need. And that we ask that lead agencies institutions wait at least a week before they send that referral to us if they're concerned about someone getting stuck. And that we have to seek to have the lead agency involved in all aspects of this work overall. Our goal really here is to supplant and enhance, or to support and enhance and not supplant the role that lead agencies have in assessment and support planning for people. So I'm just going to run through some very preliminary data from the complex transitions team, and I think the caveat I would put is this is likely not a complete picture at all. This is just representative of what has come into DHS since we've had a referral form up and live. You'll hear more about the need to fund and establish a statewide data collection and measurement system, and that what we're learning from our preliminary data very much aligns with the need for investment in that kind of a tool and resource at a statewide level. But we'll share what we know today. So you can see on the chart the breakdown of children versus adults in terms of who's referred. When we are working with the Department of Children, Youth, and Family, when there is a child protection or a child welfare issue that's involved with them, so that collaboration becomes very important, navigating those complex systems. Here you can see the reason that hospitals or other institutions have made referrals to the department, to the complex transition team. The point of note on this slide is looking at the most common reason for referral, you'll see, is the need for options for appropriate community supports. And what that means in plain language is there isn't a provider in the community that's equipped or capable of serving this person safely. And so because there are no options in the community, this person's ready for discharge, but they can't find someone that can support them with the complexity of needs, they are just at the hospital by default. So this data point to me really does align closely with report recommendations about we need to enhance provider and system capacity at regional levels in order to really deal with this problem on a systems level.
Did you guys do go back that, the needs for the appropriate community supports, that pretty high, the referral, right. Did you find, what were some of the gaps you found in that high referral point?
Sure, Mr. Chair, members, some of the common gaps that the team reports, and I think very much aligns with my experience, is, for example, someone might need awake overnight staff, and it's really challenging to be able to staff a group home or a facility to have one person awake overnight and be able to staff it on the daytime where maybe you need two staff. So staffing shortage plays a role here, absolutely. Another staffing angle that comes into play is if that person does have aggressive behaviors for whatever reason, that obviously is a harder situation and more complex, and it can be difficult to retain staff because they maybe don't feel like they have the training, tools, or support to stay safe in that environment. We do hear about, so I think those are kind of the top two, but I'd say other issues that are serious that we encounter is community resistance to establishing new developments, right? Establishing a new group home, and then some communities don't want that in their setting, or counties have concerns about that, which puts providers in a tough spot when they're ready to kind of answer the call. When they're ready to establish something and they can staff it, there are often some of those municipal barriers. And establishing new developments takes a very long time.
And the municipal barriers you talk about, are those NIMBY barriers, or are those, they are, Josh? Is that, yeah? I mean, you guys, okay. Yeah. Thank you. That's sad. You know, the thing that jumped out at me, Natasha, or Ms. Mears, was that, okay, we need options for appropriate community supports. It's like, and we want to drive that. That's what our systems approach has been, right? But it just seems that just is falling apart all around us, and so I appreciate your comment there. So thank you. Keep going.
Thank you, Mr. Chair. And then I'll say on the other, kind of on the flip side, not the flip side, but another component or angle that I want to make sure this committee is aware of is oftentimes, particularly with children, but often with adults, they have a home or a family home, but the ability to bring in a sufficient number and amount of staff into the home to stay safe and get needs met can be a challenge too. So it's both on the residential side and also in own home environments.
Thank you. To that, Senator Makewaite.
Thank you, Mr. Chair. Not to that specifically, but I'm looking at the one that says policy barriers. Is that policy of, is that laws of the state? Because that would be us, and I would be really interested in hearing those. But if it's like policies of facilities or organizations, then yes, local barriers as well.
Ms. Mears.
Senator McQuaid, Mr. Chair, that's a fantastic question, and I really would be happy to follow up and share kind of more specifically, because the short answer is it kind of lands in all three buckets, right? So one example of a barrier that happens at the state or the policy level that we have solved for but isn't yet implemented is if someone is over 65 and they've not been on Medicaid until 65, they're only eligible for an elderly waiver, and that doesn't have a rate exception to meet exceptional needs. So the legislature authorized the development of that process for EW in the last session, and we're on track to implement it. But that is a good example of a state barrier that did need legislative approval and had, some fiscal cost to it.
Senator, you want to follow up on that, the rate exceptions conversation? And the other one's a local. Interesting on the rate exception side of it. So do you have a list too as a follow-up? Could you possibly give us an idea of who's asking for the most rate exceptions? And maybe somebody already sent that to me and I don't have. Did you already send it to me? No. All right, thank you. Because it would be nice for our committee to have that. Because I don't know if you've followed the newspaper at all or seen, the challenges that this committee is going to have this year. So the door is open. So thank you, Assistant Commissioner. Keep going.
Thank you, Senator Hoffman. Okay, so I'll scoot along here with with this preliminary data that we have. So you can see here sort of the length of stay of hospitalizations. And this would typically be after a person is clinically ready for discharge from a hospital. So sometimes people stay in the hospital because they have a very serious condition and need to stay for a long time. But these numbers really represent kind of avoidable days, if you will. So as you can see, there's a fairly good spread, but certainly 50 days in the hospital is way too high for someone that doesn't need to be there.
Go ahead, Senator Mayquid, because this is causing a lot of conversation in there, so yes,
Peanut
go.
gallery over here.
You're good.
But you did, I'm sorry. Well, yes, and I'm gonna have to ask this question because I was distracted by your talking. You did mention that the days that we're looking at for length of hospitalization, are these days beyond okay, thank you, that was my question.
The answer is yes. These numbers represent days beyond when after a person is clinically ready for discharge, when the hospital says you're ready, but there isn't.
Go ahead.
Thank you. So then I'm glad you went back to the slide because then I'm looking at no shared definition of safe discharge. So if we're looking at the length of hospitalization, and that's the days beyond the time needed to be there, but then on the other one, we're seeing that there's not shared definition of safe discharge, whose numbers of days beyond hospitalization are we relying on?
So these numbers come from the department's numbers. So it would be let's see if I can explain it. Senator Mayquid, Mr. Chair, sorry about that. These represent
That's all right, I'm gonna write that up in my year-end report, so go ahead.
Thank you, Senator Hoffman. These numbers would represent stays beyond when the hospital says they're ready for discharge. So maybe to explain that a bit more, if that's helpful, sometimes the hospital is, for their own legitimate reasons, really pushing to have that person return back to the place that they came from. And the place they came from, whether that's home with parents or whether that's perhaps a nursing facility or a group home, is saying it is not safe for them, or we can't keep other people that live there safe. So it's not safe for them to come back to this spot. And the hospital say, well, this is where their home is. So it's that push-pull that is sort of represented in that data point.
Wow. Senator Mayquid.
I'll wait, I think, to the next slide.
Okay.
Yeah.
Assistant Commissioner, go ahead.
Thank you, Mr. Chair. So again, I think I covered this length of hospitalization variable. Nope, no problem. And here is just a pie chart that represents either diagnosis or the types of support needs that people might need when they're referred over to us. So I think none of this is a big surprise, but just is helpful to see it kind of broken down in numerical form. I will say that as we look at this data and kind of compare it to other data sources that are available, there's a fairly good level of alignment in terms of these are some of the core issues. Really the hardest areas are people that experience or exhibit self-aggressive or self-injurious behavior. And the reason that behavior might be happening is highly variable and can be very different individual to individual. Yep. So at this point, I'm going to hand it off to Mr. Berg to walk through the recommendations of the Acute Care Transitions Advisory Council, and I thank you for your attention.
Thank you, Assistant Commissioner. Mr. Berg.
Thank you, Mr. Chair. And thank you all for letting us talk on this topic and the work that was done. So we don't have a slide here for this, but just wanted to put into context too, this was a broad group of folks that were part of this membership of this council. I had the privilege and the honor of co-chairing it along with Laura, who was a parent of a child or is a parent of a child with lived experience. So, we brought those perspectives. I was on as an HCBS provider, so brought that perspective, but just wanted to lay out the context. We had Commissioner of Ed, Commissioner of Health, Commissioner of Human Services, County Association. So Brad Johnson, Anoka County was on there. We had Minnesota Hospital Association representation, Susan Pleasance from MHealth and Sydney St. George from Alina. We had SEIU representation, tribal government representation, mental health, local public health. We had lots of folks on here. So this, while supported and led, guided by the department and the U of M ICI group to facilitate this. This was a broad group, so I just want to really kind of lay that out there, that this was a collective of a lot of really smart people. And, I like to joke a little bit, Creighton is often called the Harvard of the Midwest, and you got 2 Creighton alum up here and only 1 Harvard over there. So a good group of individuals doing this work. And maybe Harvard is the Creighton of the East. Anyway, we put together this report after meeting for a little over a year, and the report you all have in front of you or attached. The recommendations start on page 57. Lots of background and context. Won't go into all the details of the recommendations, but we'll just say that this was broadly supported across the entire group, and we were unanimous in our work towards trying to stay high level, but get into the weeds a little bit, knowing that this is a big system and a big thing to fix or start to address. So with the guidance of the Assistant Commissioner and her team really pushing us to look for those longer term system changes, but also for those of us that are doing the work right now wanted to see some of those immediate fixes and stuff like that. So hopefully there's some balance to some of these recommendations as well. So with that, recommendation number 1 is the recommendation to continue this advisory council. We got a lot of work done, but there's a lot more work to do. I think Anoka County Commissioner or County Attorney Brad Johnson and I were skeptical. I've been on a lot of these boards and advisory councils, and as Senator McQuaid pointed out, some of these boards and groups meet to meet, and I didn't feel after going through this work that this felt different. And what I think we all want to make sure is this is not just another report that we submit to you all to then potentially act on or not act on, that it just collects dust and goes away. We want to see something come out of this, and there are many of us that are willing to put in the work and the effort to continue that and make sure that that happens. So this first recommendation really is to establish the council as a standing unit. I think time frame to be determined, and really wanting to make sure that we continue to provide that guidance and support and the collaboration with DHS and the counties. So, yes.
Senator McQuaid.
Thank you, Mr. Chair. I just wanted to make sure that you said you did feel like this was a group that was meeting and you were getting work done, and that's okay. I just want to make sure I hear that
Mr. Berg.
correctly.
Yeah, Mr. Chair and Senator, absolutely, and I will reiterate that, totally reinforced. By the time we were done, we dissolved on October 2nd when the report was due or when we submitted or whatever it was. So, but we're going to continue to work on this, whether, I shouldn't say that because I want to make sure that you guys fund it and move it forward. So we won't do the work unless you guys support it. No, it is so valid and worthwhile.
Senator Edke, are you good? Do you know, Mr. Berg and Ms. Mertz, you don't need legislative approval on this anymore, right? You do. Is it going to be in your, no? So we need to do it from here. Aha. Can we get some technical assistance on that? Thank you very much. Senator Utke would be more than happy to be the chief author on that, I think. We need to do it from the committee, Senator Utke. That was, so if we're going to extend this on. Does that make sense? Yeah. I was trying to be funny, but forget it. Go ahead, Mr. Berg.
Thank you, Mr. Chair. So again, establishing it as a standing unit with your support, more details are in there, but really knowing that the systems have to evolve. We need to spend more time with counties. We need to spend more time with providers, stakeholder engagement, and really to make sure that this council is made up of the most robust, diverse group of individuals and stakeholders. We did have some folks with lived experience, but I think we all agreed that we needed more of that and to be able to do focus groups and a whole bunch of other things. So that is recommendation number one. Recommendation number two is to expand that regional capacity for care navigation. So this really builds upon a lot of the work that Amy Peterson and the complex transitions team at DHS are doing through their 3 regions that they're working on right now. And I think what we saw too really is to build upon what is working, learn from that group, and really to establish the communication pathways between DHS leadership, the complex transitions team, this advisory council, if it were to exist moving forward, counties and all the other stakeholders. So really looking to expand that. Recommendation number 3 looks to establish a statewide infrastructure that will improve communication systems, provide coordination and support of the regions, and to monitor the development of the unified measurement system. So really looking at that data, making sure that we have that coordinated data sharing agreements, all those pieces in place to make sure that I don't want to say dysfunction, but the siloedness of our system is working together with one another and really taking into effect into account the regional differences, but then really trying to have a statewide vision for being able to move forward.
So let me ask the obvious to that one, Mr. Berg. Is the department bringing those recommendations forward, or not in any of the department bills? Especially the data sharing one that was just up there.
Mr. Chair, can you maybe reframe the question? I'm not sure that I'm understanding exactly what you're asking.
My first question was, am I expect to see these recommendations in some kind of bill format from the department? And if not, then the question is, can we get some all these recommendations, this committee would like technical assistance on that to develop something. Does that make sense?
Mr. Chair, that does make sense, and we would be very happy to provide you with extensive technical assistance to get that bill into shape.
All right. Go ahead, Mr. Berg.
Thank you, Mr. Chair. And yes, I think part of my role up here is to act as the liaison of the formerly existing council and be able to put forth the recommendations that we all as a collective brought forward, whether or not they're in some package or whatever exists right now, and happy to facilitate a lot of that and help you all do the work that you need to do to make our recommendations come to life so this doesn't just sit on a shelf somewhere.
Next one.
Yeah, recommendation number 4, integrating measurement and action plans for addressing disparities. One of the main charges of this group, too, was to look at the differences across the state, across the regions, related to geographic, racial, and ethnic disparities. And so we, accounted for that in a lot of the work that we did. We know that there's a lot more work that needs to be done there to really capture that data, understand it, what does it actually mean, and then really kind of pulling it all together to make sure that we are understanding the differences across the state.
Berg, in that one, we've seen, and I've always brought that up, the intersectionality of race and disability, right? That, because you're shaking your head. So was that conversation part of that too, the assistant commissioner, as this goes forward? Integrate measurement systems that monitor and evaluate not just the geographic, racial, and ethnic disparities, but are we assuring that the intersectionality of disability is also included in that?
Mr. Chair, yes, absolutely. I think you've really articulated it super effectively that we do see that intersectionality between race and disability type or other types of things that people are challenged with. And and often those folks with the most complex needs are the ones that are stuck the longest and experiencing the most trauma in our collective system. And so we really do need to be using data measurement to evaluate our efforts and impact and kind of that ongoing process so that we're not just doing it once and assuming that we'll have tackled that issue, that it's a very complex issue and a very complex problem. And the way to solve that in Minnesota is to create a sustainable statewide system that measures and accounts and that has the flexibility to make adjustments, bring recommendations up to policymakers. And so that's something we envision, that if the Acute Care Transitions Advisory Council were authorized to be a standing body, they would serve as sort of the leadership team that would receive policy and programmatic recommendations and level those up to leadership so that we could then, as policymakers, take the appropriate action.
That's good. Thank you, Mr. Berg. Go ahead.
Yeah,
Thank you,
Mr. Chair, and before we move on to the last recommendation, another part of that too, and that our group discussed, is there's a lot of other commissions, councils, bodies, things meeting right now, doing a lot of the work. So you got the State Advisory Council on Mental Health, the Subcommittee on Children's Mental Health. You got the work that's being done within the Department of Health, Health Equity Bureau and the Children's Cabinet on mental health. So there's lots of these organizations and groups meeting, doing great work. So could this be a way to kind of bring that all together and help facilitate some coordination and collaboration? And so we're not duplicating, we're not getting in each other's way, and we're not confusing you all when you're trying to make decisions on how to prioritize things and really solve similar or complementary problems for the state. So.
Mr. Berg, is that going to be a recommendation of that we would probably get some technical assistance on too? Is that what you just said? Because I love that idea, because that's the 3 C's, comprehensive, coordinated, and collaborative. Sorry, Jim, 99-457, but that's exactly what you're talking about. And I just absolutely, that's how we should be thinking. So thank you. Senator May-Quade.
Thank you, Mr. Chair. And it's okay if the answer to this is, wow, we have no idea. I've had a lot of families reach out to me in the last 24 hours wondering what happens if there's no federal funding for MA, or if they don't have MA. And I'm just wondering if you could, since we're talking about acute care transitions, could you talk a little bit about what would happen, or what is happening or did happen yesterday? I got a lot of scared families.
Assistant Commissioner, yeah, fair question to ask. What if the MA is no, it's gone. It was not, it's back on is what I understand. I mean, that was, right? It was never off? Go ahead, Senator Ecke. It was never off?
I don't have all the details on it, but things that affected the individual payments and stuff like them, they were never off.
Mr. Chair, the portals were down in all 50 states yesterday. I'm assuming our department can maybe confirm that. But today, the rescission of the memo was not to be construed with rescission of the federal funding freeze.
Got it.
So it's still before us.
So what was the effect of that? Because we know that the portal was down. Because I saw the DHS. What's your response to something like that? What should we know?
Mr. Chair, members of the committee, thank you for that question. It is a difficult question to answer because the situation, trying to avoid political cliches here, but is quite fluid in terms of we were surprised by the scope and reach of the original memo and quickly had to work through the commissioner's office and with MMB and the governor's office to try to understand the practical implications, which at first reading of the memo were incredibly sweeping. And then throughout the day, there was different guidance from the federal government about the scope and scale of those freezes. And so we were trying to adapt to that as well and just understand impacts. With times like this, that's the first thing we do, is we spring into action to try to understand what this means for the people that we serve and for the programs that are funded through federal dollars. So a lot of our time and energy at the department has been in doing that analysis and completing assignments. In the interim, my understanding is there has been court action to stay that executive order, but there is also a memo rescinding some of it, but it's not clear to me exactly what the implications or what that means. So we're in a very ambiguous situation. I can share what we're doing is really trying to plan and anticipate as best we can, prioritizing maintaining programs and services if at all possible, but it is a very scary time in that regard relative to a sudden cutoff of federal fundings for key programs.
Senator Rasmusson, then Senator Abler, unless Senator, no, you're good. Senator Rasmusson.
Thank you, Mr. Chair. And question for the Assistant Commissioner. Are you aware of any federal grants that DHS is expecting money for that hasn't been paid?
Assistant Commissioner?
Mr. Chair, Senator Rasmussen, I'm not aware of that, but I would like to check with the team and get back to you on that question.
And Mr. Chair, I would just say, you know, when they're, let's make sure that we're talking about concerns and issues that are playing out. Like I've thought from my conversation with the agency that it's pretty clear that MA wasn't affected, that I think it's been reported on nationally that the issue with CMS's portal wasn't connected to the executive order. And so I just want to make sure we're talking about actual impacts to people and not just hypotheticals. And would just say, you know, just point that out. We can, as impacts are felt by DHS, please feel free to bring them to the committee. Thank you, Mr. Chair.
That's good, and I'm glad we're doing a good job keeping out of that political portal. Senator Abler.
One, I think that we're circling it pretty well. I think that helping us understand what is, all I know is what I saw on some news thing, and it's not supposed to affect individuals. What does that mean? And so is Alexandra House at risk? I would like to know some of those answers that are good. And so we can spend a whole hearing on this, but it would be nice if you could maybe update something daily. It's not how I would have done this particular order, so I can't. We should try to spend less time being unhappy about whatever's going, at least in your role here as ostensibly nonpartisan people trying to help us just understand what is, so we can deal in facts. That's all I'm after. And so maybe you can work out a memo a lot of people want to know, and it'd be appropriate for this committee and the other health committee in the Senate here to be informed of that with your best knowledge, with just as raw facts as you can help us. Like, this is what it is, this is what it isn't. And then, oh, by the way, it changed, now it's this. That would be helpful to me. Thank you.
We're going to add that to the new, when we get the technical assistance on the acute care transition team, you're also going to get, but to Senator, I mean, you can tell that there's a lot of angst about, you know, what is unsure. Medicaid in Minnesota, right? We look at the big bucket that both our health and our human services, $25 billion, the state invests $30 billion at Fed. That $30 billion is whether or not this nursing home is going to stay open or closed, right? And so stuff like that. So I feel that angst, and I don't want to, you know, maybe with the committee, it'd be nice to get some kind of, you know, oh, by the way, here's an update on stuff that happens like that, just so that there isn't false information being shot around or people going, oh, what do you know, what's happening there? So, Senator Makeway, did you want to follow up on anything? And then I think Senator Gruenhagen wanted to give us his update from Glencoe.
Thank you, Mr. Chair. And you know, I definitely do want to talk about what is before us. You know, this is before us, right? I think it is appropriate for us to talk about. Yesterday, the spokesperson was asked about MA, said, I don't know, I couldn't tell you, I'll get back to you. And so, if, you know, we're creating a 2-year budget. The court order goes away on Monday, and so it's Wednesday, and I think it would be really helpful to know in front of this committee, like what we could be facing on Monday, what constituents could be facing on Monday. And I know it is really unclear, but you know, that's why I bring it up. It's not for fun. I have like freaked out families, parents, reaching out to me saying like, what is it? And from the back end, if there haven't been federal grants that hasn't come in, do you know when the next, like, is 2/1 the next time that there would be a host of money coming in? Or I guess I'm just looking for like the next date where we should be looking for something. Is Monday the date? I mean, I'm trying to, or if it's as sweeping as the executive order was, like what does get turned off? It's just so hard to wrap my head around.
It's interesting because Senator Rasmusson just showed me, Elise Bailey sent out so much for getting, you know, she sent out information yesterday regarding this specifically to emails to all of us. And so yeah, right? Is it? Chairs, yeah, chairs and to staff. So, you know, I would, maybe that's up to us. The information's coming from the department, then we got to make sure that this is getting to the committee. So, you know, we could do that, make sure when those things come. So that's good. Senator Gruenhagen.
Oh, thank you, Mr. Chair. Yeah, just a quick comment too. I've read articles and information just like the rest of you, but You know, basically, the articles I've read, some in the Star Tribune, is that he was simply, it was simply going to pause the executive order, which has been rescinded, a judge put a hold on it, to review the funding to be in line with his executive orders that he signed, which addressed transgender surgery, Green New Deal, and DEI programs, which he seems committed to eliminating out of federal funding.
Yeah.
So, but the thing is that I do think it's a time for all of us, and I mentioned this before when we had a presentation on the increase in Medicaid as far as our spending is concerned. We are on a path that is unsustainable in terms of funding. I mean, we're at 36 trillion, we're headed to 40 trillion, and that's just the general fund, much less all the other funds. And I do think that we need to think things through in terms of reforms, because sooner or later, our children are going to suffer under this, and or something else is going to come out of it.
You know what? I apologize. I ended up asking a question that we ended up getting off topic, and now we're in the weeds on something else. And Senator Abler just reminded me, I have a question. Let's get us back on the topic thing when we were sitting there. So see how easy it is, the fear and stuff about, this is because we are doing real work, right? I mean, the people we care about are the most vulnerable. And, you know, it starts with somebody's proposal to cap services. And so that has got me just keeping up at night. And this is why this piece that you're doing is so important to me. So I apologize for getting us off topic, and I will bring us focus back in on what you were doing there. Mr. Berg, back at you.
Sure. Thank you, Mr. Chair and members. And maybe to help pull us back into that, Senator McQuaid, it was a really good question and a comment, and I can bring it back to St. Paul specifically with some issues where when MA turns off because a county can't process MA eligibility forms or something in a timely fashion, it results in the individuals that we serve sitting in hospitals or coming back to our settings and their skilled home health getting turned off. Their access to wound care doctors and specialists gets turned off. Their access to medications that they need gets turned off. And then we get stuck in a situation where we're potentially running the risk of going outside the scope of the services that we could or should be providing, but we don't want that person to end up back in that hospital because we don't know if we'll get them back home. And that's where this type of what happens, it affects real lives. And we're seeing that happen right now based on situations of counties, lead agencies, and others that don't have the capacity and are making decisions that impact eligibility, access to services that are resulting in things like this. And that'll get us to recommendation number 5 in this.
This is good. Senator Abler does have a question germane to what you're just doing, but that's an important piece.
No, it's a really important topic. It's we talked about this last year, and I'll try to be as polite as I can. I was hoping in the governor's budget there would be some attention with a dollar sign in front of it to address this. And all we came away was a task force and or advisory council, and a very nice one, and a report, and there's information that we had. It looks like about a third of the people in your plot graph there with 222 had just nowhere to go. So a third of them don't need any new research to figure out. There apparently were like 175,000 hospital days over what period of time, in a year or whenever, that exist, and money for everything else on earth in the last 2 years, and precious little for this, not even rebasing. And so I'm happy for the technical help, but I tried in the conference committee 2 years ago to steal some money from something that I thought was not a good thing, as important as hospitals. That was not successful. But the needs are there, and the beds are full, and the very people that we're all committed to serve, which are people in MA, and the people that are the people challenged with disparities and equity problems are disproportionately reliant upon medical assistance and Minnesota Care, and it's our job to do it. And I don't know. I mean, I don't know who the governor is deciding these things, and you could expect this comment from me on this topic. But, Mr. Chair, as an entity being St. Paul in this complex, we have to do better. And amongst the highest priorities of what we have to maintain are hospitals and their functionality. And they are backed up, and people who really need to get there, who have some acute issue, are in the ER forever, and there's no bed. And to the population that we all say that we care so much about, the administration says they care a lot about that. And so I'm just pointing out that we have to do better, and if the governor, whoever the governor is in this matter, takes messages back, there should have been something about this in the budget, and we'll work on it here. But then when it comes time to, like I praised Mr. Storkamp for staying on message. Well, that's the law. If you change it, we're going to follow it. And by the way, the governor says this. So can you remind them this is really important? I guess I'll leave it at that. Thank you.
So interesting that Senator Abler, the hospitals were here today. There were some social workers that talked about this point on the transition, and they were pointing out the hope to try to get something where Department of Human Services and Department of Public Health communications on the transition, so this moving thing. And I was, looking forward, this is what they were also dealing with there too. So I don't know, maybe our friends from Mercy Hospital should kind of come and hang out. Did Brad Johnson talk about those folks? I mean, just the whole piece on transition and where we're at.
You mean closing pediatric beds? Oh, that's a different topic.
Jeez.
Mr. Chair,
Senator
can the two
Abler.
of you just have a suggestion? Yeah, we almost got that fixed. Pediatric beds matter.
We almost.
I didn't mention Blue Cross today in a disparaging.
I'm
so
actually,
that's pretty good. So between the two of you, can someone volunteer, but someone should work on this and try to flesh out this business, not me, but some other member of the committee who has a real interest in this, if they could put in some time.
You used to do that for years. When you were chair for 6 years, you would say, "Oh, by the way, you got." We give Glenn Grunhagen.
I don't want to lose
You
this.
should do that. No,
there's
I'm
too
kidding.
much good work here to have it to.
This is really good work,
So,
Josh. I mean, you were
Thank you,
hitting.
Mr.
This is
Chair.
exactly what Senator Abler's saying. I've been waiting for this report when I heard you guys are meeting, and the meetings are there. And yeah, does that make sense? No, I think we're there. Thank you, Senator Abler. Mr. Berg.
Yeah, thank you, Mr. Chair. I'll wrap up and be quick here. This last recommendation is really then to identify barriers and initiate more immediate or short-term policy changes. So this is the fun one for me, where I get to push the departments and look at, or we get to look at different ways and solutions that might be causing barriers or be causing issues for the transition of folks out of hospitals. So, I mean, I think this is the one that captures some of the questions and the comments that got brought up earlier related to some of those NIMBY barriers, some of those licensing barriers that include, do we have the right licensing constructs to support somebody? Are there the right waivered services right now that can meet the needs, or do we need to tweak some of those? And I think you'll see some potential bills and recommendations coming forward from other groups. Policy barriers, and I can't say it, if I get the opportunity to be in front of you all to talk about license capacity issues and ICS and some of the work that we need to do in that area, I think that will be of focus moving forward. And then, with some of the other topics that have been brought up in different proposals related to capping or ending customized living services for individuals with disabilities under 55 on CAD EIDBI without alternative replacement options for those folks, we're going to see, these numbers skyrocket potentially. And the last thing I would say, this group, as I mentioned at the beginning, was a broad group of really passionate people looking to fix the system. I think we can continue this work if given the ability to do so. It's going to, Senator Aki, Senator Abler, and others, there's going to be a fiscal note that is this is going to cost money. There was a conversation a couple weeks ago where a leader at an agency made the comment to the effect of, as we transition folks out of hospitals, it's actually going to cost the system more money because unfortunately, those hospitals are eating the cost for a lot of these individuals because they're not getting paid for these services. So if we actually find appropriate services in the appropriate settings, it might actually increase some costs, but trying to find that balance, of course. So with that, I will be done.
Thank you very much. I really appreciate the update on this, and unless there's any other member questions or discussion, we'll move on to the PACE report. Thank you. Assistant Commissioner, whenever you're ready.
Thank you, Chair Rasmusson, members of the committee. I am pleased to present I'm here today to talk about the PACE program in Minnesota. I'll be providing a brief history of PACE development in Minnesota, an overview of the model, and then talk about how PACE could fit into existing service models related to integrated services and managed care, and then share some of the key findings from the implementation report. Next slide, please, Ms. Grom. So PACE is not new to Minnesota. We've laid out just a timeline here. We made an initial run at PACE following several years after it was authorized at the federal level, but weren't able to identify providers at that time that were interested in responding or establishing a PACE program or be a PACE provider. Certainly there has been lots of renewed interest in the community about PACE and its impacts, and so you can kind of see over there we were directed by the legislature last year to conduct an actuarial analysis and an implementation analysis for kind of what would it take to stand up a PACE program in Minnesota and how does it fit into the rest of the services and supports. So we'll be talking through that a little bit. This is just a reference slide with the legislative language. I think we can move through that, but you've got it if you need it. So quick overview of the PACE program. PACE is a program or a model that is authorized by the federal government, but its design is to serve people, elders in our community, and that are otherwise eligible for institutional levels of care to help them stay healthy in their communities and in their homes. So this model is a home and community-based service for people that are 55 and older that live in an area, a geographic area where there is a PACE provider, has to be a provider of services, and they meet a skilled nursing facility level of care. So they would otherwise need nursing home care if they didn't get services through PACE or other settings. PACE is authorized with the federal government, so it would require a state plan amendment. It's a sort of a three-way agreement between the PACE organization or organizations that are selected, the state administering agency, which is DHS in this context, and then the Centers for Medicare and Medicaid Services at the federal level. The thing, just go back one more. I think the primary feature of PACE, how it differs from a fee-for-service model, is that there is the establishment of a per member per day capitated payment, and then PACE providers receive that payment on behalf of the enrollees they're serving, and the provider of the PACE services has to have the financial wherewithal or the financial resources to manage the risk that's associated with just getting a capitated payment. So this slide just represents sort of the interdisciplinary model of how PACE works. So as you can see, there's a variety of disciplines and professions that sort of wrap around the member, and there's a strong care coordination element of it to make sure that the services that are being delivered are making sense together. So if you need physical therapy following a broken hip, you might also need occupational therapy to regain some of your mobility or need a different tool to be able to navigate your home and prepare meals, things like that. You might need a dietitian if you've needed some help with wound care or nutrition, for example. Next slide.
Senator Abler wants to know if there's chiropractic.
Answer that. All right, so what's included in a PACE model, or what services are included in the capitation rate that I just mentioned? So it covers Medicare Part A inpatient, Part B outpatient, drug benefits, and all covered MA benefits. Additionally, PACE programs have a physical plant, a place, to provide typically adult day services, but then that can also be the place or their location where PACE members can access primary care, therapy meals, some of the other things you see on that list there. So we've talked a bit about capitation. So the feds pay the capitation rate for the covered services, and then DHS pays for the Medicaid services as the state Medicaid agency. So there's kind of that split between Medicare and Medicaid. An important feature of PACE is that the capitation rate per member has to be less than the amount that the state or PACE otherwise would have paid for that person to access different services if they weren't in PACE. Another key piece of background here as we kind of shift into what services are in Minnesota right now that look a little bit like PACE in our managed care is We have a fully integrated dual special needs plan, and I'll try to avoid all these acronyms, that closely mirrors some of the functions of PACE right now. Next slide. So just what Minnesota has in place today is our MSHO program, Minnesota Senior Health Options for people that are 65 and older, eligible for Medicare and also eligible for Medicaid. So you can see for people that are on Medicaid waivers or elderly waiver, there's a coordination across the Medicare and Medicaid benefits and the home and community-based services in this case. Care coordination is a key feature of the MSHO program, and MSHO programs are also required to develop a model of care that includes that foundational promoting a care plan, monitoring quality, and things of that nature. So that's what's currently in place today. When we look at the literature, both PACE programs and MSHO have shown studies to have lower rates of hospitalization and higher rates of employee satisfaction, which is probably not a surprise, as we know that when we make an intentional effort to coordinate care across all the different disciplines and modalities of our healthcare system, when someone helps with that and helps the person make choices, they typically get better outcomes. So we see that as a really consistent finding. I also want to point out Minnesota offers a integrated dual special needs plan for people that are 18 to 64 with disabilities. However, the key difference in this context is that the home and community-based services, the waivered services, are carved out of the SNBC plan. So they're not integrated into that model. So one of the things that PACE would add is it would be a model it would be the only model that could coordinate and support an enrollee's Medicare, Medicaid basic care and long-term services and supports for people that are 55 to 64. So they can access the disability waivers at that age. So that would be a new benefit or a new offering. And just to give you some sense of context, nationally, there's about 180 PACE organizations that operate in 33 states and the District of Columbia and serve about just over, 80,700 participants. In Minnesota, we have 25,000 seniors enrolled in MSHO that meet kind of the same type of eligibility requirements that would exist for a PACE program. So that's kind of the overview of where we are, what we have today, what PACE could potentially offer as an additional service model here in Minnesota. So now I'm going to dig into some of the meat of the reports that we've been working diligently on along with external partners. So we've done the actuarial analysis, partnered with an accounting firm. In both the implementation report and the actuarial analysis, we have been very intentional about including external partners, providers that have expressed interest in PACE, people that really believe and support this model. And so we feel good about the level of engagement and the transparency that we've had in terms of here's what the actuarial analysis is, and here is the implementation report and some of the things we need to consider if PACE moved forward in Minnesota. We shared the implementation analysis in May of 24, a kind of final draft version. So the implementation analysis report contains the different bullets that you all can see up on the screen in terms of the considerations and sort of the things that Minnesota would need to do in order to establish a PACE program that would be that the federal government would consider approvable. So areas of consideration, if we were to move forward with the PACE program, are some of the things you can see up on the screen. I think of particular incidents here is trying to make sure that we have a good system in place for PACE providers to look at critical incident management and health and safety issues. We know that the point of PACE is to keep people living in their home and avoid nursing facility stays with coordinated care. And even when people are getting excellent care in their homes and well-coordinated services, life still happens, things still happen. And so being able to provide and set up a system that's really going to be effective and align with other state efforts to investigate critical incidents is going to be really important. Again, here, just more considerations for the committee. This is just highlights from the report. We'd have to think about kind of the compliance piece with auditing and financial reporting, member outreach and marketing, making sure people understand they do have a choice. They don't have to be enrolled in PACE, that they're making a free and informed choice to elect that service model. And what do our quality assurance metrics look like, and what are our measures of success of this program, and are all going to be important things for us to figure out. So wanted to give you a sense of timelines here if we were to move forward with a state plan amendment. I know many folks on this committee are familiar with the process for getting approvals from the Centers for Medicare and Medicaid Services, but the process really does start with Minnesota submitting a internal planning development and review, so not the final state plan amendment, but a document that kind of outlines our intentions and allows CMS to give us feedback, tell us to look at this, say this thing's not going to work, you need to rework that. And then following that, we would then make adjustments based on that and then submit the state plan amendment, putting us on the clock for CMS, where they typically have 90 days of, in order to approve up or down. And then they're typically, the process is CMS will then ask questions of the state. Maybe they'll set up a meeting and say, what about this, this, and this, because this is the official document. And then DHS has an opportunity to respond to those questions, comments, concerns. And then CMS has an additional period of time to approve the final application following that back and forth. So if we were successful in getting federal approval, just laying out some of the steps here, we would be seeking for a notice of intent to apply. Then there would be a formal application, and then reaching that agreement that would be based on the approval that CMS provided us. That sort of provides the bones or the foundation of the requirements that we would require of PACE providers, as well as any additional state level requirements that we establish. And then we would have to also conduct a state readiness review for the PACE organization prior to them actually officially coming open and taking on enrollees. So some of the staffing considerations for Minnesota, what we've laid out here is that there are administrative resources that are involved in standing up a new program. And so just laying those out, that it is absolutely something that we know how to do and can do, but really will need administrative resources to do it successfully and set the program up for success. So you can see some of the reasons there just to kind of lay out what our thinking in terms of the administrative resources. Part of this report also includes how did other states do this. We know that PACE is operating in 33 other states as well as the District of Columbia. So this is just a snapshot of what other states have done in terms of staffing needs, what's worked for them and what hasn't. I think we can anticipate that if PACE moves forward and there's a legislative appropriation for those administrative resources, it might be a question of kind of front loading some of those resources to get the program up and running and then moving into a more of a maintenance and operation, which might require fewer staff. But that's kind of the way we're thinking about how we would implement this. All right, other considerations you can see up on the deck there. And also just thinking about the timeline to be able to actually make PACE a reality for people will be dependent on the provider's ability to be ready and our ability to communicate effectively with those PACE providers about what the requirements are, what we expect. So there's some fungibility here, but definitely think that this is something with resources that we could do if that's where we want to go. So in terms of next steps, we would need, administrative resources and appropriation to begin kind of rebooting the PACE program. The other key piece of note that I wanted to share is we have released a request for information of potential PACE providers, sort of a first step, to collect some basic information about the, who's interested, how many people would they think about serving, what kind of staffing ratios are they thinking about, rate development and challenges. So responses to that RFI close on February 28th. So we're very much interested in what kind of response to that RFI we'll receive, and we'll continue to work with external partners on those responses and what it means for implementation.
Senator Abler.
Well, thank you. And, I've been trying to get this far for a long time, so it's kind of sleeping. I thought it's PACER. Like, oh, PACE, wait, I better pay attention. Well, I'm happy you did the RFI. I'm happy we're kind of moving in that direction. It was the thinking it's going to save 5% or something. Was that the idea that we've been talking about, or do you have an idea how much we're going to save from the baseline to get this going?
Assistant Commissioner.
Chair Rasmusson, Senator Abler, I believe we would need a fiscal note to assess the savings. I am not sure right off the
Yeah.
top of my head here.
I'm just, Mr.
Senator
Chair,
Abler?
and just, so I'm just wondering what the experience of other states has been. I just thought it was in the 5% range or something, and might be a good time to get some tail savings going. And so I'm glad we're moving forward. I know the time's getting long, but so if we're going to advance this year, so you have an RFI out in the governor's bill, not trying to be facetious, but is there a page about moving this along and the administrative request you have for that?
Assistant Commissioner.
Mr. Chair, Senator Abler, just to be super clear, the RFI is not included in the governor's budget. That's initiative that the team took to just issue a request for information to kind of get a sense of the lay of the land in the provider community right now.
And so, Mr. Chair, so if we wanted to
Abler.
move it ahead, and I thank you for your initiative there. So tell them it's a good idea. So tell me you really like this. And it's actually going to help with this budget problems and actually quality of care issues, I think, from what I hear from the glowing tales. We'll see how that goes. But so then we would need, you would need some staff, 4 or 5 or something staff to get this going. Is that what I gleaned from your notes there?
Assistant Commissioner.
Chair Rasmusson, Senator Abler, we would certainly need additional administrative resources. I don't want to put a number on it without having done a fiscal note and talking to the internal teams about what it would really take, but we could certainly get that information.
And Mr. Chair, and
Senator Abler.
so if we wanted to, but that would be necessary in this budget to actually hit a target of January 27 implementation, right?
Assistant Commissioner.
Chair Rasmusson, Senator Abler, can you repeat the question, please?
Well, if
Senator
you wanted
Abler.
to get going, it says in the report, it could be done as soon as January 1st of 2027. And so if that's going to happen, you would need people to get going on this. And Ms. Grom has a lot of free time. I believe she's at least silent, horizontal, some numbers of every evening. When there's nothing, it's very quiet and you can get a lot of work done, but she might want to sleep. Could you enlighten us on that and so we can chat about what technical information you might want and some kind of a budget? It seems to me even the leanest of times, some of these things to do make the sense to do, to take what's limited and put something toward this. So thank you.
Mr. Chair, Senator Abler, thank you for that question. I think from a timeline perspective, there are quite a few variables that would impact a final implementation date, including, I talked before about sort of the process of getting a state plan amendment approved and the 90-day clocks. And so there are times that CMS will take us off the clock for technical assistance to put us back on. So there's ambiguity in the timeline relative to that. I think what's laid out in the slide deck here is a best case scenario. Yeah. The other thing that can impact timeline is the provider readiness to meet the qualifications that CMS requires Minnesota to have as a part of that agreement. So I think, if you all want to request technical assistance on this, we can take it back to the program experts and lay out maybe a best case scenario and then a not best case scenario and back into timelines for you to give you a sense of that.
Thanks, Mr. Chair. All I was but if we want to get going on this, we need to find a few people to start working on this and pay for them in this budget cycle. That's my real question. And then you'll go do whatever. And actually, I only want the rosiest of reports, so none of this downside stuff. Thank you.
Thank you, Senator Abler. And it's definitely some member interest on looking to get this implemented, and so look forward to continued conversations in the committee and with the department. We also have a testifier joining us on Zoom, so I'll hand it over to Miss Mary Austin. Miss Austin, would you please introduce yourself to the committee and present your testimony?
Good afternoon, chairs and members of the committee. I'm Mary Austin. I am a registered nurse and the CEO of Bold Age PACE. We're a provider of PACE in 5 states, 6 programs in 5 states. I thank you for the opportunity to testify today in response to the DHS report about implementation of the program of all-inclusive care of the elderly. We really believe that implementation of PACE statewide is the most impactful thing that Minnesota can do to take care of an aging population. I'm a nurse, as I said. I've spent my career, over 30 years, caring for older adults and their families, including 20 years in PACE. I've seen challenges that families have navigating, it can be a really fragmented, confusing, often overwhelming healthcare system for that population. And PACE really, I've seen it firsthand, really provides life-changing impact for older adults and their caregivers and the communities that they live in. It's a holistic, team-based model that really enables folks to stay in their home and in their communities. I'll also add that I myself was a caregiver for aging parents and really understand and dealt with the issues that face families and caregivers, with these really complicated situations, and how difficult that is when there's not a PACE program available, as was in my case. I would like to address 3 points in the summary of the report for your consideration. And they are accessibility, regional considerations, and rates. As far as accessibility, as noted in the summary of the legislative report, PACE really mitigates with staffing, it mitigates the accessibility issues with staffing and a real understanding of the community that it serves. I always say PACE puts its arms around its members, participants is what we call them in our program, puts its arms around those folks and really provides such comprehensive care in a very accountable way. So it's really by design built to coordinate care and to partner with communities in providing that care. At Bold Age, we have a program in Fresno, California, where we have partnered with a community organization, as we've done in other areas too. In Fresno, we partnered with a provider of adult day services to an Asian immigrant population, primarily Hmong population, who find it very difficult to access services that are culturally competent and really address their needs. So in partnering with that organization and being able to bring PACE, which we know, to them and support them in providing PACE services to their population, we've had a whole lot of success in doing that. PACE is kind of custom made for that sort of a relationship. Thinking about regional considerations, especially rural areas, we all know that especially seniors in rural areas have great difficulty usually accessing services. And PACE has really proven itself to do really well in bringing services to the rural populations. In many states, PACE is growing readily, including our program. We have a program in Kentucky and another one in Indiana that have a pretty wide rural area, and we've been able to access and bring services to participants because it's a way, with the transportation services and the blend of community-based services as well as an adult daycare model, which we have incorporated into our program. We can really bring services to folks in rural areas, in a way that other programs can't. And then finally, I'd just like to address the issue of rates. There was a discussion about variable rates to successfully implement PACE, certainly a robust discussion. The selection of PACE quality PACE providers needs to understand that really the complexity of serving this dually eligible population. We believe and we advocate for developing an equitable PACE capitated Medicaid rate structure that's nuanced, has a nuanced approach, meaning that it really takes into consideration the complexity of this population and the cost experience of this population. PACE serves a very high risk, high acuity population. So they have expected higher costs and frailty than comparable comparable groups of folks within the same age and communities. So we advocate for a blended rate structure that accurately accounts for all of those, the comprehensive nature of the care provided to these very complex folks. So by providing person-centered, very practical solutions to meeting the needs of the frail elderly, PACE is very successful. The things as simple as providing for nutritional services, such as, home-delivered meals or center-based meals. PACE can often mitigate long-term healthcare issues, even social determinants of health, depression, loneliness, have significant impacts on individuals as they age, leading to problems with other chronic diseases, hospitalizations, and eventually long-term care placement. And PACE is very successful in mitigating these issues with all the socialization that it offers. And of course, in addition to the socialization, PACE provides really intense person-centered healthcare. So a provider, a physician or a nurse practitioner in a PACE program typically serves about 100 individuals, 100 patients. So relatively small caseload for a practitioner. And so they can provide really very exquisite, unique person-centered care that addresses issues early and really prevents those long-term effects of hospitalizations and eventually nursing home placement. So again, I really appreciate the opportunity to present to you, talk about PACE and how we believe it's a wonderful way to meet the diverse needs of aging communities across Minnesota. Thank you for the time and the opportunity, and I'm happy to answer any questions.
Thank you, Ms. Austin. I have one question for you. Are you responding to the RFI that DHS has put out? Right, you heard about it? Okay, good.
Happy.
Any member discussion, questions on the PACE report or for any of our testifiers? Senator Gruenhagen.
Oh, thank you, Mr. Chair. Yeah, thanks for the presentation. So what is the percentage? Usually with federal funds, there's also state commitment. Is there a ratio between the federal dollars you draw down versus what the state would have to provide?
Assistant Commissioner.
Chair Rasmusson, Senator Gruenhagen, I believe there is a federal match. I am not exactly sure the percentage, so we can definitely get back to you on that. I'll take that back to the team. It should be a fairly straightforward answer.
Thank you, Assistant Commissioner. And it's my understanding that this is all within CMS, and so the whole idea is the reason the state would do it, the reason CMS would approve it is if there's cost savings, or at least it's staying within the costs that would otherwise be spent. Is that correct, Assistant Commissioner?
Senator Rasmussen, yes, that's correct. The PACE program requires that the capitation rate per member would be less than the state would otherwise spend on services.
Thank you, Assistant Commissioner. Any other member questions? Senator Acute.
Thank you, Mr. Chair. What is the schedule on this, or what is the future? Are we going to hear more? I mean, we've heard some different things. And, one of the questions was cost, and Senator Abler kind of had most of what I was originally thinking, but we did reference other states. I mean, are we going to get some of that data to know a few more of the details rather than just saying we need a fiscal note? I mean, we've got, at least from what I see, at least 3 other states that it'd just be nice to get some of that feedback. I mean, don't need testifiers or anything like that, but it's to receive the data. Is there a savings? What is the savings that they saw, et cetera, so that we know moving forward?
Thank you, Senator Aki. And Assistant Commissioner, I don't know if in any of the more kind of detailed reports that you have developed as a part of this process, if there is that information or not, but just wanted to see if you had any response to Senator Aki's question.
Mr. Chair, Senator Acute, we've absolutely issued several reports on PACE, and there are some details in the implementation report and maybe some things that might be of interest in the actuarial analysis. So I'll take that back to the team and we can pull together kind of excerpts of different reports that we have that might give you a better feel for it.
Senator Acute.
Thank you, Mr. Chair. Actually, like this bigger packet that we had included today, is that where it should be?
Assistant Commissioner.
Chair, Senator Acute, I believe so. What I would want to do is go back to the team and make sure there might be other documents or other reports that also might be relevant to your question. So I think it would be a matter of us just kind of compiling the resources and making it easy to access. But yes, certainly recommend reviewing the implementation report as a foundation.
Thank you.
Thank you, Senator Ackie. I guess, Assistant Commissioner, like one question I'd have for you and the department would be, like, do you think this committee should, move forward with PACE? Do you think it would be something that would be beneficial to the state of Minnesota, beneficial to the work that the agency is doing, or do you, given your reports and time studying this issue, think it's not the right priority for us to be thinking about?
Senator Rasmussen, Chair Rasmussen, I think PACE is a well-established model that does work and provides a lot of important benefits, similar to what the testifier talked about. I think in our assessment, we do have a fully integrated kind of managed care product that does a lot of the things that PACE does. And so I think from a policy perspective, it's sort of weighing what do we have versus what does PACE bring to the table. But what I will say is that I think in the external partners that we've been working with, there is such a high level of support and commitment to this model that part of our job as well is to really listen to those folks and help them identify the path forward and identify path forwards for you as legislators to determine if the investment, meets your legislative and policy priorities.
Thank you, Assistant Commissioner. Any further questions, discussion from members? Great. Well, I think this conversation will continue, and I know there's a number of members of this committee that are interested in doing more work on PACE, and so appreciate the information and reports here today and any of the follow-up that was discussed. Just given the time that we have remaining and the importance of the next topics on the agenda, I'm going to suggest to the committee that for the EIDBI licensure study in particular, and for the obsolete rules, that we're going to reschedule that for a future committee date. And we're going to make sure that our committee administrator reaches out to every individual who has signed up to testify to ensure that they know about that future date. And the reason for that is we just want to make sure it's an important discussion. We want to make sure that everyone who would like to testify on that issue is able to do so, and that we're not having to cut off testimony. So appreciate members of the public and their patience with this committee. We just want to make sure it has enough time to be fully discussed. Anything else, members, before we adjourn for the day?
We'll follow up with the obsolete rules report too. You want to, Mr.
Yes,
Chair?
yeah. We'll also, for the obsolete rules report, we'll also reschedule that for another time, and we'll let the department know when we'd like to have them come back. So with that, the committee is adjourned. Thank you.